Philippe Inger will explain how to assess patients with multivalvular disease. He will illustrate in two cases the interaction between two valve lesions. He will also elude the importance of using the less dependent methods on the loading conditions in this particular setting.
So I've been asked to demonstrate the difficult topic of multiple valve disease, and obviously I will not be able to show every situation of these complex situations, but I would like first to start with the case of a patient who present aortic stenosis and mitral regurgitation. So let us start with this parasternal long axis view, where we can clearly see that there is depressed left ventricular ejection fraction and a posterior akinesia, but you can also notice that there is some problem with the aortic valve. And zooming on the aortic valve, we can clearly see that it is calcified with a reduced opening. I will now go on the apical view, where we can see that there is a depressed left ventricular ejection fraction and that the lateral aspect of the left ventricle is also akinetic. So let us now turn on the color flow modality, and we can see that there is also some degree of mitral regurgitation, and we will go back on this a little bit later. But I think that in this situation, the first thing we have to do is to make the differentiation between the aortic flow and the mitral flow, which are both recorded in the apical view as negative flow. So it's important to make the differentiation between these two flows. And you have here the aortic flow, and let's now get the mitral flow. How can we make the difference? If we go back first on the mitral flow, we can see that the start of the flow is within the QRS, whereas for the aortic flow, it starts after the QRS. It's clearly later than the previous flow. And obviously, a major difference will be that the mitral flow has inherently a greater maximal velocity as the aortic flow. So after having made this differentiation, we will try to record the highest velocity flow, and this is from the apical view, where we can see that the maximal velocity here is around 3.3 meters per second, but I will ask the patient to turn on his back, and I will try to record a better flow from another window. So this is the flow that we can record from the substernal view, with the patient supine and the head turned left, and we will try to see if the maximal velocity is higher, which is not the case, so I will continue to use the apical continuous wave flow for what the aortic stenosis is concerned. So let us go back on the left ventricular outflow tract. And in this case, we can make later a measurement of the flow of the left ventricular outflow tract diameter in order to perform the aortic continuity equation, which remains valid in the presence of mitral regurgitation. And I will take the pulse wave in the apical view flow in order to perform correctly the aortic valve area assessment by the continuity equation. So we can see that the left ventricular outflow tract diameter is 21 millimeter. And we can also measure the left ventricular outflow tract velocity, as well as tracing the contour of the aortic flow, which allows us to calculate an aortic valve area of around 0.8 square centimeter. Please note that the maximal velocity of the aortic flow is around 3.5 meters per second, and the mean pressure gradient is around 27, and these findings are consistent with the diagnosis of a low-flow, low-gradient aortic stenosis. And it's important to remember that in the presence of mitral regurgitation, it is a frequent finding, which may be a little bit tricky in terms of diagnosis of the aortic stenosis. Let's go back on the mitral flow. And a good way to assess the severity of mitral regurgitation is to remember that because of the extremely high afterload induced by the aortic stenosis, we will have to rely on the measurements which are the less dependent on the loading condition, and the measurement of the effective regurgitant orifice by the PISA method is probably one of the best methods to use because it is less load dependent and it has been shown to be less dependent of aortic valve replacement, meaning that after aortic valve replacement, the effective orifice area is less changing than other parameters, more load dependent, such as the color planimetry or the regurgitant volume. So to measure the effective regurgitant orifice by the PISA method, we will zoom, we will make a downward shift of the color flow baseline, and this will allow us to calculate a radius, and by tracing the contour of the continuous wave mitral Doppler flow, we can assess the severity of the mitral regurgitation, and in this case we have a 0.2 square centimeter of effective regurgitant orifice. We can also use the mitral regurgitant flow to further assess the severity of left ventricular dysfunction by performing the DP-DT assessment, which in this case is lesser than 600 and thus consistent with a severe left ventricular dysfunction. Please note also that the flow is central and that there is clearly some tenting of the mitral valve, which is thus consistent with functional secondary mitral regurgitation. And it's important to classify, to describe the mitral valve, because functional mitral regurgitation are much more likely to regress following aortic valve replacement in the case this patient should undergo surgery. And in this case, thus, it's more likely, because it's functional mitral regurgitation, that this will spontaneously decrease after unloading the left ventricle by the isolated aortic valve replacement. So, to summarize this case, I think that it allows us to emphasize the importance of the loading condition in this combined condition. It's important to remember that we have to assess the effective regurgitant orifice, which is the best way to assess the severity of mitral valve disease in this case, and that we have to make the diagnosis between functional and organic mitral regurgitation, because functional mitral regurgitation is more likely to regress following an isolated aortic valve replacement. So this second case is the case of a patient presenting mitral valve disease, mainly with stenotic mitral valve and some degree of aortic regurgitation. And I think that this case also will help us to emphasize the features which are important to be taken into account in this complex situation. So let's start here with a brief overview of the case, and we can see here the parasternal long axis view, and you can see that mitral valve is not opening normally. There's a hockey stick appearance of the mitral valve. There's a dilated left atrium. Left ventricle seems to be correct. And in the short axis view of this mitral valve, we can see that there are commissural fusions and also some calcification of the anterior mitral leaflet. Let's see again this parasternal long axis view. Left atrium is markedly dilated, and we can see that there's no significant aortic valve disease, at least no stenosis of the aortic valve, but we can see from this color flow Doppler that there is some degree of aortic regurgitation. And I will not go into details for quantification of aortic valve regurgitation, but please note that using the vena contracta, it's a 4 millimeter consistent with non-severe aortic regurgitation. So let's go now in the apical view. And we have here the aortic regurgitant jet using the continuous wave modality. It's also consistent with non-severe aortic valve disease, aortic regurgitation. So this is the mitral flow from the apical view. And in using this view, we can thereafter measure the mitral gradient. This is the apical view using the color flow Doppler. And you can see that there is no significant mitral regurgitation in this case. We can measure the pressure gradient across the mitral valve, which in this case is around 11 millimeters of mercury. And we should remember that this measurement is not sufficient for assessing mitral valve disease because it's highly flow dependent. So we will have also to measure mitral valve area to be confident in the severity of mitral valve disease. We can first use the pressure half-time method, but in this situation, when there is some degree of aortic valve regurgitation, we should remember that the pressure half-time is not fully we cannot be fully confident in measuring mitral valve area using the pressure half-time method because the pressure half-time is usually shorter in the presence of some degree of aortic regurgitation. So this is not a perfect method for assessing mitral valve disease in this case. We can also use the continuity equation by using the left ventricular outflow tract measurement, the pulse wave Doppler at the level of the left ventricular outflow tract, and using the continuous wave of the mitral valve. But in this case, we should remember that because there is some degree of aortic regurgitation, the flows across the mitral valve and across the aortic valve are inherently different, and therefore the continuity equation cannot be used in this situation. So the best method in this case will be to make a planimetry of the mitral valve, and that's what we will do here. First by zooming, trying to obtain the best measurement at the tips of the leaflets. And in this case, we obtain a 1.1 square centimeter, which is consistent with a moderate to severe mitral stenosis. In this case of multiple valve disease, we can also use another method, which is the PISA method. And this method, the PISA method, is in this case perfectly usable because it is not affected by the presence of any degree of mitral regurgitation or by the presence of aortic regurgitation. And I will not do the measurements, but first we have to zoom on the mitral valve to make an upward shift of the baseline. And then we can measure the radius. In the case of mitral stenosis, we will usually have to make an angle correction because the plane of the orifice is not flat, and we will usually use a correction of about 100 degrees, thus multiplying the result by the 10 divided by 11. So, and we can see in this case again that the pressure gradient is 11. An important thing not to forget is that we have to remember that assessing tricuspid regurgitation and tricuspid valve disease it is of the utmost importance because it might impact the decision-making process. Should we perform or not a procedure on the tricuspid annulus? And in this case, you can see that there is some degree of tricuspid regurgitation. We can see also that trans-tricuspid velocity are slightly elevated with a trans-tricuspid pressure gradient of around 32 millimeters of mercury. Please note that the inferior vena cava is not dilated and shows inspiratory reduction consistent with non-elevated right atrial pressure, more than 50% reduction in this case. And we can use the PISA method for assessing tricuspid regurgitation. Ideally, we should assess the respiratory variation by measuring the PISA method in inspiration and in expiration, and by averaging the two measurements. And in this case, we can see that the radius is 0.6 centimeters, which allows to calculate a regurgitant orifice of 0.4 square centimeters, consistent with moderate or even almost severe tricuspid regurgitation. An important thing in this case is to assess the tricuspid annulus, because in the setting of moderate or more tricuspid regurgitation and a dilated annulus, there's an indication for performing a tricuspid annuloplasty should the patient undergo mitral valve surgery. And in this case, please note that the measurement is 39 square centimeters, which is almost significant, with the cutoff of 40 millimeters, but we might also index this measurement, and if more than 21 millimeter per square meter of body surface area, this is consistent with an operative indication in this case. So I think that this case perfectly emphasizes the importance of assessing the valvular regurgitation and stenosis using the adequate methods, and we should remember that one valve may act on another valve by changing the loading condition and the flow conditions.
So the key points of this examination are that we have to avoid confusion between mitral flow and aortic flow, for example, that conventional measurements can be wrong, that we have preferentially to use effective regurgitant orifice and planimetry measurement, and finally that we have not to forget the tricuspid valve that can play an important role in the management strategy.